briefly discuss cystic renal diseases and tubulo-interstitial diseases. Now, you know that we have discussed different types of conditions. We've discussed CKD, AKI, we've discussed glomerular diseases, and today I'm going to discuss tubulo-interstitial diseases very briefly and cystic renal diseases, and of that, I'm mainly going to discuss autosomal dominant polycystic kidney disease. And in tubulo-interstitial diseases, acute interstitial nephritis, chronic interstitial nephritis, and a little bit about chronic CKDU. So out of the cystic renal diseases, polycystic kidney disease becomes the main disease entity that you need to be aware of. There are so many other conditions where you get cysts developing in the kidneys, but for your purposes, for final MBBS, you need to know mainly polycystic kidney disease. So it's an inherited nephropathy, and the commonest, the predominant one that you need to know is the autosomal dominant polycystic kidney disease. But apart from that, you have other inheritance patterns where you can get an autosomal recessive as well as sometimes sporadic polycystic kidney diseases as well. In the autosomal dominant polycystic kidney disease, you have two genetic abnormalities that can mainly happen. One in chromosome 16, which is the PKD1 gene, and in chromosome 4, PKD2 gene. And these are two numbers that you need to know because for your MCQ purposes, they sometimes can give this chromosome number. And what is interesting to know is that depending on the type of the gene that's affected, the phenotype or the way these patients clinically progress differs. For example, if you have PKD1 gene abnormality, these patients develop end-stage kidney disease much earlier, by about in their 50s, as opposed to the PKD2 type, where they have a very protracted, slow progression, and they will not develop end stages until very late in their 70s and 80s. And the disease condition is characterized by uncontrolled cyst growth that alters kidney structure and progressively impair kidney function. Now, this is what happens. So in polycystic kidney disease, what happens is you have your nephron where you have the glomerulus and the tubules. And because of these genetic abnormalities, there will be small outpouchings like this that happens from the tubules. And with time, these will gradually enlarge and enlarge. And all these are the stimulations that will increase the cysts. And they will detach from the tubules and form large cysts. And with time, there will be a lot of material that's going to get produced into this cyst, and the cyst starts enlarging, and the number starts increasing, and the cyst starts enlarging, and that is how cysts develop in polycystic kidney disease. And in these conditions, you have complications associated with polycystic kidney disease. When you talk about the kidney, as your kidney gets bigger and bigger with the enlargement of the cyst, you can imagine the capsules are going to get stretched. And that's going to cause more and more pain for these patients. These cysts can get infections occurring within them, and you can develop cyst infections. Some of these cysts can develop calculi within them, and you develop problems related to calculi with obstructions, pain, hematuria, conditions like that. These cysts can sometimes rupture, and that can cause severe pain as well in these patients. And you can imagine when the cyst number and the cyst size starts enlarging, with time, the parenchyma, the active tissue in the kidney that is functional, is going to grow small and small. And these patients end up with significant CKD and end-stage kidney disease. And some of these patients actually get erythrocytosis, where your hemoglobin level starts going up. And this is thought to be mainly erythropoietin mediated because of this compression. Sometimes there is a surge that will cause more and more hemoglobin increase. Extrarenally, these conditions can associate sometimes with hepatic cysts. Now, this is important for you to know, especially with your short cases and all. When you are doing an abdomen examination, if you get a polycystic kidney disease patient, you always have to palpate for the liver as well to see whether there's hepatomegaly, which could be related to hepatic cysts. They can associate with berry aneurysms, and sometimes these patients can develop intracranial hemorrhages. So if you get a patient for a long case, you need to ask a family history of his cerebrovascular accidents, strokes, limb weaknesses in the family, and also ask whether there have been anybody with similar illnesses in the family. And in your short cases also, you need to demonstrate that you are looking for limb weaknesses as well. They can sometimes associate with mitral valve prolapse. So you are expected to keep the stethoscope into the precordium and listen for any mitral valvular abnormalities. So this is the natural history of polycystic kidney disease. You can see on this axis, this is age of a person. And on this axis, you have kidney function. So at the beginning, their kidney function will be 100%. And you can see gradually with time, there will be more and more cysts developing. And because of this cyst, the kidney starts getting bigger and bigger. So initially, these patients will develop pain, hematuria, stones, infections. And gradually, these patients will start developing hypertension and proteinuria. But if you notice, their kidney function remains stable for a long time despite the kidneys enlarging and having these complications. But when it starts going down, then the kidney function rapidly goes down. That is because till the last stages, whatever kidney parenchyma that is preserved in these kidneys are able to maintain kidney function and GFR. But by the time it starts dropping, by that time the kidney doesn't have any reserve, and your kidney function starts rapidly going down. And these patients go into end-stage kidney disease very, very fast. So how do these patients develop hypertension? These cysts, there are many theories. One of the main things is that these cysts cause compression on the renal vasculature and the renal structure, which causes more and more renin, angiotensin II, aldosterone secretion and stimulation. And this whole pathway is going to get stimulated, and that is going to result in hypertension in these patients. And it becomes a vicious cycle where this hypertension is going to damage the kidney more and more. So in the management of polycystic kidney disease, control of hypertension becomes very, very important and crucial. So how do we diagnose? And so one way is the imaging. You need to do ultrasound scans. Depending on the age of the patient, the criteria will vary. If you are between 15 to 40, you need at least 3 unilateral or bilateral renal cysts. 40 to 60, you need at least 2 cysts to be seen in each kidney. And more than 6 years, you need at least 4 cysts in each kidney. However, the gold standard way for you to diagnose this is by doing a genetic test. And once you diagnose a person to have a polycystic kidney disease, it's very important that you do family counseling. You need to advise them regarding the importance of genetic screening or family screening. If they are having children, normally, I mean, they need to only do ultrasound scans. There's no point doing scans before the age of 20 years because you can hardly see any cysts in the majority. And these need to be done only after 20 years of age. If you need to do genetic screening, first these patients and the family need to have genetic counseling. And if they have consent only, you should go for genetic testing in these patients and family. So in the treatment, there are a few medical treatment that's available now. One is we advise them to take an increased amount of water intake, and the importance of that I will mention to you in the next slide. Blood pressure control becomes very, very important, that like I mentioned, and our preferred antihypertensive drugs are your ACE inhibitors and your angiotensin receptor blockers. They need to go on a salt-restricted diet, mainly because of the salt and water retention and the hypertension. And now we have this new medication called tolvaptan, which is a vasopressin antagonist, which is one of the main drugs that is now used in the management of polycystic kidney disease to control the growth of cysts and the enlargement of cysts, which can be used, and it's available in Sri Lanka as well. So how does water and this tolvaptan act? So if you take how the cyst develops, you have a tubule cell proliferation, the cysts enlarge. And this cyst enlargement is stimulated by cyclic AMP, which is stimulated by your antidiuretic hormone or your vasopressin through your V2 receptors. And if you can remember your physiology, if your antidiuretic hormone or your vasopressin is suppressed if you take more and more water. So that's why you encourage them to take a high intake of water, whereby this ADH stimulation is less and your stimulation to the cyclic AMP becomes less and less. And the tolvaptan that you are going to give is going to block the stimulation of the V2 receptor, thereby reducing enlargement of this cyst development. And that is how that drug works for these patients. Now that's all I'm going to talk to you about polycystic kidney disease. And the next group of drugs is your tubulo-interstitial diseases. So they are mainly where the tubule and the interstitial component, meaning the interstitium, gets affected by different causes. And you can divide this mainly into acute interstitial nephritis or chronic interstitial nephritis. So acute interstitial nephritis, as you know, as you can see by the name, this is the parenchyma of a renal biopsy. And you can hardly see any glomeruli or tubules, but in the interstitium, you can see all these inflammatory neutrophils that have come into the interstitium. And that is when you call it acute interstitial nephritis. Clinically, these patients present sometimes with fever, very non-specific arthralgia, skin rashes, and because these kidneys are full of inflammatory cells, the kidneys get swollen, enlarged, and you develop flank pain, loin pain because of the capsular stretch. These patients sometimes develop acute kidney injury, and if you are having acute interstitial nephritis secondary to certain drugs, in the full blood count, you will see an eosinophilia at times, and if you do a urine fluid report, sometimes you will get eosinophil urea as well. And on the ultrasound scan, your kidneys may look swollen. And if you do a urine fluid report, sometimes you will see white cell casts, hematuria, and even eosinophils in the urine sample as well. So what are the main causes of acute interstitial nephritis? You can mainly divide it into drug causes, infective causes, and systemic causes. Drug-induced acute interstitial nephritis is the main group of causes. There are antibiotics like cephalosporin, ciprofloxacin, penicillin are some of the main drugs that can cause acute interstitial nephritis. And also your analgesics, especially your NSAIDs, can also cause an acute interstitial nephritis. So the common infections become your hantavirus, leptospirosis, which can affect the tubules as well as the interstitium. Around 8% you can't actually identify a cause, so then you call them idiopathic. And systemic conditions like your lupus, Sjogren's, sarcoidosis, these are common conditions that can cause an acute interstitial nephritis. So you need to know some of these causes because again, these can be tested in your MCQs. So how do we manage them? If you know the offending drug or if you are suspecting an offending drug, the main thing is that you need to stop that immediately. And if these patients have developed a significant acute kidney injury, you manage the acute kidney injury as you have discussed in your lecture on acute kidney injury. There is a place for steroids. If the kidney functions are not improving or rapidly worsening, there is always a place for a short course of steroids, which will reduce the inflammation of the kidneys. And this sometimes will cause improvement in the kidney function and rapid resolution of the acute interstitial nephritis. Similar to acute interstitial nephritis, you have the chronic interstitial nephritis. And as shown in this picture, this is again a renal biopsy where you have a glomeruli here, you have tubules here, and the interstitium, you can see this lymphocytic infiltrate that has come in between all the tubules and infiltrated the interstitium. That is when you see this picture with lymphocytes predominantly in the interstitium, you call this as chronic interstitial nephritis. Here, it's a slow onset, slowly progressive condition. The symptoms are very minimum compared to your acute interstitial nephritis. Sometimes these patients will complain of vague back pain, aches and pains, but it becomes very non-specific. If you do a urine full report, it's a very bland sediment. Sometimes you might have a little bit of protein, but it becomes a bland sediment. And ultrasound kidneys are also very variable. Sometimes you can have shrunken kidneys because this is the chronic process, and the kidneys sometimes get fibrous because of a chronic inflammatory process, but it could be of variable sizes. And sometimes you might see significant CKD features as well. The causes are more or less similar to your acute interstitial causes, but you need to know one of the commonest causes is this analgesic nephropathy, where patients are on NSAIDs for joint pains, back pains for months and years at continuous periods. And that is one of the commonest causes that we see that give rise to chronic interstitial nephritis. Apart from that, metabolic causes like hyperuricemia, hyperoxaluria. So hyperuricemia is where your uric acid levels are high. Some patients like this can get gout as well, and that is one cause of chronic interstitial nephritis. Diseases like lupus, sarcoidosis, infections like Epstein-Barr virus, cytomegalovirus, and then you have this miscellaneous group of conditions like Bolker nephropathy and CKDU. So CKDU is chronic kidney disease of uncertain etiology. By definition, is a chronic interstitial nephritis for which we do not know an underlying cause. Now that brings us to this topic of chronic kidney disease of uncertain etiology, which is endemic to Sri Lanka and some other countries all around the world. Now, your renal lectures will not be complete if we do not discuss at least in briefly about CKDU, which you all need to be aware of. So you can see this this top heading. This was a report that was published in some papers and reports, and this was done in year 2000. One of the first reports where somebody had identified water quality and specific kidney diseases in Morawala, Gomarankaduwala and Kapithikullava areas in the north central regions of Sri Lanka. And after that, starting from 1999-2000, there were a lot of kidney disease patients that were identified in the north central regions of Sri Lanka. And around the same time, all around the world, if you notice this world map, in Sri Lanka, Andhra Pradesh, in India, Egypt, Mesoamerican countries like Nicaragua, all these areas, and you can notice the similarity. It's all around this belt in the world map. Patients with chronic interstitial nephritis with CKD, where people could not find an underlying etiology. So a similar problem started in Sri Lanka, or it was actually noticed for the first time around this time. And if you look at the Sri Lankan map, this map shows, this is a bit old map up to 2015, but these are areas, the highlighted areas are the ones where these patients started appearing. And these dark red areas are where they are highly endemic compared to the others. So this is, you can see, mainly involving the north central and over areas of Sri Lanka. And if you overlap this map with the dry and the wet zone according to the rainfall of Sri Lanka, you can see that this is mostly affecting the dry zone areas and hardly any patients reporting from the wet zone in Sri Lanka. So then people started try to start identifying what's actually going on. These patients were detected through screening programs, where asymptomatic patients were detected in mass screening programs. Some of these patients presented with very non-specific symptoms like backache, feverish feeling, arthralgia, dysuria. And if you can remember, I mentioned that these chronic interstitial nephritis presents with very vague symptoms. So some of these patients present like this. And there were some patients who for the first time just presented in end-stage kidney disease without having any other symptoms at the beginning of their illness. And these are some of the field screening programs that were conducted in very large scale, and whole villages, people came for these screening clinics where we tried to identify CKDU among the populations. Then satellite renal clinics were established in these highly endemic areas. So this is in Madhavachya, this is Girandarukote, this is Padaviya, all very endemic areas for this CKDU of Sri Lanka. And clinically, these patients are predominantly male patients between the ages of 40 to 70 years of age. Majority of these are paddy farmers with low socioeconomic status, and most of them consume water from dug wells or tube wells. And when you investigate, they only have a little bit of proteinuria and very non-specific clinical symptoms, like I mentioned, back pain, aches and pains, arthralgias, very, very non-specific. And when you do a kidney biopsy, you get this typical chronic interstitial nephritis pattern where you have all these diseases. So these are your tubules, this is your interstitium, and you can see this infiltrate of lymphocytes. And that is the typical hallmark lesion of this CKDU patients. You do an ultrasound scan, again it looks like a CKD kidney, where sometimes the kidneys will be small, shrunken, increased echogenicity with loss of corticomedullary demarcation. So you can see the kidney here, and you can see the high increased echogenicity with poor corticomedullary demarcation of this kidney. So we still, then people try to identify why are these patients developing this CKD, and there were many theories. And what people noticed was all of this happened around a lot of socio-economic changes that happened in Sri Lanka in the 70s and 80s. The Mahaveli project, the new settlements started happening. Farming, the practices of farming started changing. There was a lot of commercial farming with the use of agrochemicals. Global warming started happening. There were tube wells. People started using more and more tube wells around the same era. There were changes to food habits. So there were so many socio-economic changes that occurred as well. And now it's nearly been 25 years since we've actually started knowing about these conditions. And still we exactly don't know what the underlying etiology is. There are many theories as to what might be causing this CKDU in Sri Lanka. And some of them are environmental factors like fluoride, aluminium, water hardness, cyanobacterium, heavy metals like cadmium, arsenic, agrochemicals like glyphosate, infections like Hanta and lepto. Some people think that it could be genetically motivated, where these patients have a genetic predisposition for this. Some people relate it to lifestyle factors, because this is mostly among farmers in the dry zone. This could be heat stress related, dehydration related. So there are still many theories, but nothing has proven to be the exact etiology of CKDU. So in the absence of a known etiology, we are at the moment only managing the CKD. And the CKD, the principles remain the same as we have discussed in the previous lecture of CKD. You have to discuss about stopping smoking and alcohol consumption, provide them with good quality water, dietary management according to their CKD stage and the complications, management of all complications of CKD and progression factors such as anemia, hypertension, bone mineral disease, and avoid the use of nephrotoxic agents. And this is provision of good quality water to these areas where people are using different ways of getting good quality water. Rainwater harvesting is one of those things that is done in some parts of the country, where they collect all the rainwater directly into a collector and use that for their personal consumption. Some areas, they have reverse osmosis water plants that have been installed to clean the water. Some places, there are water bowsers which are still giving them water, and there are water purification plants that are also being established in certain parts of the country. So there are different ways people and the government are trying to provide good quality water to these areas. And at the same time, organic farming and toxin-free agriculture is being promoted in order to take out the fact of agrochemicals that is being contributing to this. Right, so thank you. And it's a very short lecture. but I think that would cover most of the renal things that you need to know. Any questions anyone wants to ask about what we have discussed today?